Thank you everyone for joining in the rounds today for the opportunity to present. So like Dr. Chow said, I wanted to do a case-based rounds based on several of the cases that I've seen that I know the lab sees quite often in terms of assessment of these patients who have transcatheter edge-to-edge repair, especially given the focus of St. Mike's on quite a bit of structural interventions. I think this is a really relevant topic for us. But also, I think, we will see a lot more and more of these patients, and how to perform these post-procedure echocardiographic assessments, I think was basically my question and my inspiration for trying to learn a little bit more about this. So my objectives are to review the echocardiographic assessment of valvular regurgitation after percutaneous interventions. And more specifically, I wanted to discuss device-related leaflet adverse events and discuss mechanisms of recurrent regurgitation after these interventions. So I have no relevant disclosures, but I do have one disclaimer, is I'm neither interventional cath fellow nor a structural echo fellow and have minimal expertise in this, but I know a lot of people in the room and online may have a lot of expertise. So I would be I'd really love to hear your thoughts, your experiences with assessment of these patients, and make it more of a discussion afterwards. So I'll start off with a case. This was one of the cases that I saw that kind of inspired this talk. So this was a 78-year-old male who has a known history of heart failure, preserved ejection fraction, atrial fibrillation, CAD, hypertension, CKD, also has CMML, presenting with recurrent right-sided heart failure exacerbation. So he had he had some assessment of his valvular disease by transthoracic and transesophageal echo, and this found a massive functional tricuspid regurgitation with a central coaptation gap. He ultimately was thought to be very high surgical risk, and so underwent a tricuspid clip with the intention to actually place 2 clips. The first clip was placed. This was an XTW between the anterior and the septal leaflets, and the tricuspid regurgitation at that point was reduced to mild moderate. There was some additional attempts after that, 2 attempts actually to place a second clip between the anterior septal and the posterior septal leaflets, but they were both unsuccessful. And so the decision was made to just leave with 1 clip, and he had mild moderate mitral regurgitation. So just so that we can visualize what happened, this was just some clips from the intraprocedural TEE. This is an on-fast view of the tricuspid valve in the transgastric view, and you can see the posterior leaflet, the anterior leaflet, and the septal leaflet, and there is this clip where you can see that the delivery system is still attached at this point between the anterior and the septal leaflets, somewhat into the, close to the commissure of the leaflets. And then this is just color over that same view to demonstrate that there is certainly not severe, and mild. In other views, they decided that it was mild to moderate. So in the immediate post-procedural transthoracic echocardiogram, was actually done on the same day, you can see in the RV inflow view, the tricuspid clip is seen here attaching the anterior and the septal leaflet. And there's really not much, mild, moderate regurgitation, or moderate regurgitation ultimately was decided based on other views as well. This is in the apical 4-chamber view. And interestingly, you can see part of here, because of the position of that leaflet, of that clip in sort of that commissure of the anterior septal leaflet, it almost looks like it's attached to a single leaflet, where in fact it isn't. It is attached, as we can see in the inflow view, to both of the leaflets, but it's not attached to the posterior leaflet. Or the septal, the other parts of the anterior leaflet, sorry.
Actually, it's a good example of how on the apical 4-chamber view, the lateral leaflet is either the anterior or the posterior leaflet. So on the apical 4-chamber view here, the leaflet on the lateral aspect, that's the posterior leaflet, but it's definitely not attached to it.
Yeah. Yes, yeah, as this looks more like this is the posterior leaflet, given the fact that it isn't attached. So with this view as well, you can see there is, this jet area isn't as big. We don't see the vena contracta or the proximal flow convergence as well on these views, but ultimately this was thought to be approximately moderate. And then this was the hepatic vein Doppler flow, and you can see there's actually, you don't see systolic reversal in the hepatic vein flow. And so this suggests that there has been significant reduction in the tricuspid regurgitation. So the patient actually developed initial improvement in his shortness of breath, but over the next 1 to 2 weeks while being hospitalized, he was still having persistent declining energy, edema, and he wasn't responsive to any diuretics. So the team decided to repeat a transthoracic echo and to reassess the clip. And so this was performed 12 days after the procedure. And back to the same inflow views. Sorry, I'm not sure why it's not looping. But as you can see here in the 2D view, you can already see that whereas previously we saw a very nice inflow view where the leaflet or the clip was attached to both leaflets, that doesn't seem to be the case anymore. Although in this view we don't really see exactly what the clip is attached to. And then we put color on there, and there's certainly a lot more color. There's clearly a coaptation gap now between the two leaflets, and there's what looks like severe tricuspid regurgitation again. Here on this plane, you can see more that the clip is probably attached to the the septal leaflet. So the sonographer continued on, and we are looking at a sweep actually in an off-axis 4-chamber view. And so this highlights one of the ways that I think is important in assessing these types of clip is doing multiple sweeps actually to look at exactly where the attachment of the device is. But here we can more clearly see this is sweeping sort of anteriorly, posteriorly, that the clip is attached to the septal leaflet, but is now not attached to the anterior leaflet. And by color, there's significant amount of regurgitation. There's a large vena contracta as well, and you can see proximal flow convergence very easily here. And then in the CW Doppler, there's a more triangular shape to that profile, which I know I didn't show you the transthoracic echo or the transthoracic echo just after the procedure, but I can certainly say that this is very dense triangular severe TR. And then if we look now at the hepatic vein, it's obviously having systolic reversal, which is suggestive of recurrent severe tricuspid regurgitation. And so this demonstrates a case of what we call single leaflet device attachment, which we'll go into a little bit more. So just coming back to the basics, transcatheter edge-to-edge repair, I thought would be best if we kind of, for my understanding as well, go back to what are all these names of these types of clips, what has been the evolution. So, there's been there's now 4 generations of clips, of mitral clips. The first generation was classic, the second was the third was NTR and XTR, each of them, and then the last the most recent is NTR, NTW, XTR, XTW. With NTR and XTR, there were longer arms related to these clips so that they can grasp more tissue. And as we advanced, the width of the clips also increased in the NTW and XTW in 4 millimeter and 6 millimeter width. And this allowed over the progression of the generations to grasp more tissue and basically wider coaptation gaps and be able to treat more complex mitral anatomies that were previously not treated and were really strictly in what was the original Everest inclusion criteria. He also developed some additional technologies. For example, the 4th generation clips have an independent grasping mechanism, which means that instead of simultaneously grasping these leaflets, the leaflets can be grasped one by one, and so that improves the leaflet grasp allows for better grasping, which I'll show you is actually really important to prevent these leaflet adverse events. The other types of mitral clip devices are the Pascal devices, where there's 2, and they are made of somewhat different material. They're made of these flexible arms of nitinol, whereas the mitral clips are made of these rigid arms of chromium alloy. The other difference is that the Pascal devices have a spacer device. So you can sort of see in the picture that they have this device up here. That's the spacer, which actually allows you to bridge more of that coaptation gap, so to be able to implant in larger coaptation gaps. So those are some of the differences and the array of mitral clips, and these are used for tricuspid clips as well, that we have on the market right now and being used. And just to remind us, there is now Class 2A indications for use of for mitral transcatheter edge-to-edge repair. In the setting of primary MR, this is a 2A indication, and it's reserved for patients who have primary severe MR with symptoms, but higher prohibitive surgical risk. And so if they have a favorable anatomy, they would be indicated for a mitral tear. In secondary MR, they're also indicated if you have LV dysfunction with significant symptoms, but fail optimal medical therapy. And they define appropriate anatomy as per the COAPT trial to ensure that they would likely have a good outcome. So how does this actually happen in the procedure? I thought these were actually nice graphic simplified, but graphic assessment of what happens during the procedure. And I come back to this not because I'm not focused on intraprocedural guidance, but more so to understand how these elements during the procedure actually really affect the post-procedure outcomes. So in the most left-sided graphic here, just basically demonstrates that the device with this delivery system and the clips are advanced through the femoral vein into the right atrium, through a transseptal puncture goes into the left atrium, and then it crosses actually the mitral valve into the LV, and then the arms and the delivery device is pulled up to the position of the mitral valve at the region of the mitral regurgitation. And then I want to just go through what happens is better seen, I think, on this graphic on the right side of how they actually do the grasping and the sequence of events. But basically, as you can see, the top is sort of cartoon representation. The bottom is intraprocedural TEE. And you can see as the tricuspid, as the TEER device, the clip arms are first passed through the mitral valve, and then they're pulled up to the mitral valve. The arms, you want to make sure at this point that the leaflets are inserted into the arms. And what the arrows here are showing is that these graspers, which actually have frictional elements and hooks on them, are then sequentially, or as in these newer generation clips where you can have independent grasping mechanisms, are then sequentially closed and positioned. You can certainly reposition the devices still at this point because the delivery system is still attached. And then ultimately you close the clip in this way. And then the delivery system, as in the picture D here, is then taken out, and at this point you've released it and you're not able to reposition it at that point. So that's how the devices are implanted, or a very short version of how the devices are implanted, just to give us an idea of what's going on. In terms of evaluation, I think more relevant for us is seeing these patients after the procedure and deciding how to evaluate these regurgitation or the presence of residual regurgitation. This was actually sort of a consensus guideline was provided by ASC in 2019 through this paper called Guidelines for the Evaluation of Valvular Regurgitation After Percutaneous Valve Repair or Replacement. They weren't focused just on TEER, but certainly transcatheter edge repair was a major component. So I'm going to first go over evaluation of mitral TEER. So in terms of echo evaluation, why we perform the echoes at certain time points, I just wanted to kind of come back and point that out first. So we usually perform a transthoracic echo one day, or on the day actually immediately after the procedure, and then at 30 days. These two studies are mainly to look for complications, and those are device-related complications, pericardial effusions, and the acute results. So to what degree of reduction in regurgitation was achieved. And then at 6 to 12 months after the procedure, you're still looking at the integrity of the device as well as regurgitation, but you're also looking for any evidence of adverse remodeling based on changes in the LA or LV size, improvement in PA pressures. And so those are something, hopefully we do see reverse remodeling after reduction in mitral regurgitation. So one of the things that's obviously very important is to look at the morphology of the valve, to look at the device integrity. So what is the position of the device? Is it where they had intended to put the device? What is the stability? Highly mobile devices is highly suspicious for an abnormality, although that might not always be the case, as some of the cases I think would later demonstrate. And then as we can see in this picture, this classic peristernal short axis view where we can see the clips actually creating this double orifice where this clip is in the center and there's one orifice medially, one orifice laterally. Over time, these fibrous fibrous connection is formed actually as a result of the clip, and that's what's called the tissue bridge post-clip. We do also want to look at interaction with adjacent structures. In these cases, for example, the interaction of the clip with any chordae. Is there any abnormality to the chordae? And then not necessarily in clips, but for example, in a transcatheter mitral valve replacement, interaction with the LVOT is very important to look at. So probably the most important aspect of imaging and regurgitation, any kind of regurgitant lesion, and but particularly in these post-TEER patients, would be color Doppler imaging. And we're looking for all of the essential components that we would normally look at: the number of jets, the site of the jets, the direction, the eccentricity. And that peristernal short axis view with the double orifice can be very helpful to identify how many number of jets are they located medial or lateral. But there's some unique challenges to doing this with post-mitral TEER patients, which I've listed here. First of all, they're more likely to have more than one jet because of the fact that this double orifice is formed as a result of this clip. As you can see in these examples here on the left side, there are, you can have three jets, you can have up to 5 jets. The jets can be very eccentric just because of the way that the clip anatomically changes the regurgitant orifices. They can be wall hugging, or they may crisscross like in picture C here, which makes it much harder to define the severity. And they may also be shadowed, and often actually shadowed by the prosthetic material, which may be more than one. You may have a mitral clip in a patient with prior annuloplasty, for example, or mitral annular calcification itself can also create some shadowing that makes it difficult to see. And so one of the things I found that wasn't necessarily listed in all of the reading that I did, but I think we've done this a lot. I'm sure you guys are already familiar, is doing all of these sweeps to actually get a look at where the jet is, where the location of the clips are relative to all the other components. And so that can be very helpful. So just to give some examples of what may be considered mild, moderate, I mean, these are kind of ways that we all also assess native regurgitation. So but they do apply in the setting of post-clip patients. So mild, these Doppler jets tend to be more narrow, small. They don't have much aliasing, as you can see here. And you don't really see much of a flow convergence. In the setting of at least moderate to mitral regurgitation here, you can see that there's a larger color jet area. There's aliasing of the color. It fills a larger component of the left atrium, and you may be able to see some flow convergence, but this is in this example in particular is not very obvious. One of the ways we assess mitral regurgitation natively is also using vena contracta, but there's minimal data on the use of this vena contracta areas or width for residual MR after mitral valve interventions. And the guidelines really limit the use of vena contracta width to the setting of annuloplasties where you still have a native valve in place and where you have one jet, because the vena contracta, when you have multiple jets, becomes more complicated and you may underestimate or you may need to make it additive. You may need to add up the vena contractas. One of the ways that has been discussed is using 3D TEE to measure vena contracta areas. You can actually summate them, and in some studies, they have found that it correlates with improvement in NYHA class at 6 months. but it is quite cumbersome. I mean, this is done through a TEE. We have to do 3D imaging. And vena contractors are still susceptible to things like gain dependence, looming artifacts, and they may actually overestimate, if you add up all the vena contractors of all the different regurgitant jets, may overestimate your euro in these cases. So this is maybe one of the better ways to really quantify regurgitation in this setting, but it still has some limitations. So the next way we can assess as using proximal flow convergence. And the guidelines actually recommend using them qualitatively, but not quantitatively, because there's a couple of limitations unique to patients after mitral tear. One of them is, again, multiple jets, and they tend to be much more eccentric, so it's harder to align your Doppler against these jets. But the other thing is that the Pisa shell itself can be constrained by the clip. And so you may need to actually perform angle correction in these cases as a result of that. But you can sort of qualitatively assess the same way that we do in native regurgitation. So if the Pisa is less than or equal to 0.3 centimeters, it's more likely mild residual MR. If Pisa is greater than or equal to 1 centimeter, then it's more likely severe. And we can put a CW through it, and very similar to how we look at native regurgitation, mild tends to be sort of a faint parabolic CW Doppler, whereas in a moderate or more, it will, like in native, be much more triangular, more dense of a jet. The other thing that's quite helpful is mitral inflow patterns. When you have a significant reduction in mitral regurgitation after edge-to-edge repair, you may actually see a reversal from an E-dominant inflow into an A-dominant inflow, as can be seen here. But although it's sensitive for reduction in MR, it doesn't necessarily is not necessarily specific, because it can be influenced by a lot of things, by the mitral stenosis that has been created after repair, by LV filling pressures, and obviously this can only be assessed in the setting of sinus rhythm. Peak V velocity, we do mention, is something that could be followed over time. If you see that perhaps there's increasing mitral regurgitation over time as you're performing surveillance in subsequent studies, then the peak E velocity may actually increase over time, and that could be an indication of mitral regurgitation. Pulmonary venous Doppler flow patterns, as we know, have this, you may reverse that once you reduce the MR so that you have more systolic predominance rather than systolic reversal. But again, this is affected by other things like an elevated diastolic pressure, atrial fibrillation. So while they're suggestive, they may not be exactly specific. One of the ways that they do recommend is using regurgitant volume fraction by sort of these volumetric methods. So you do a total stroke volume using biplane Simpsons or 3D LVEF, and then you take the stroke volume, the forward stroke volume out of the LVOT, and you subtract that from the total stroke volume, you get a regurgitant volume. And in the setting of mitral regurgitation from TEER, this would actually be a appropriate and reasonable way to assess regurgitant volume. But you're invoking multiple measurements, you're going to introduce more error as you measure more. And it's feasible assuming there's no significant area of regurgitation and there's no VSD present. The other thing we want to always assess is transvalvular gradients after TEER. As part of the full assessment of the valve and the integrity of the device. And what they have found is that an elevated transmitral gradient more than or equal to 5 millimeters mercury is sort of the consideration of mitral stenosis and do have worse prognostic outcomes. What can predict that is having any annular or leaflet calcification, baseline mitral valve area of less than 4 centimeters squared, baseline mean gradient of greater than or equal to 4 millimeters mercury, or having multiple jets at baseline, which I assume is because they may need multiple clips, for example, to correct that. Elevated gradients can also be another suggestion that there may be significant mitral regurgitation as well. So that's one thing to remember as we're looking at these patients. So the guidelines kind of go through these, color Doppler, spectral Doppler, and quantitative parameters and list some of their limitations to assessment. Some of the areas where they're quite applicable, but there are, as you can see, quite a few limitations as I've highlighted as well. So ultimately, with all types of assessments, they do advocate for a multi-parametric assessment of regurgitation post-tear, just like in really native regurgitation, but there are a couple of differences, which I kind of pointed out. One is that PISA but EuroA is not really reliable afterwards. They don't necessarily recommend doing that, but using PISA more quantitatively. And certainly the regurgitation volume and fraction, instead of using PISA, you may want to consider using volumetric method. Ultimately, though, if you have poor quality TTEs, you have discordant measurements, you should really consider a repeat TEE or CMR actually for quantification of how much residual mitral regurgitation there is, or to determine if there's other complications. So what kind of complications can happen? Well, there are both device-related and procedure-related complications. I won't go through procedure-related complications today because that's less relevant for us. In terms of device-related, it can be structural failures or functional impairment in which you have residual MR because of, for example, there may be hemodynamic changes during the procedure that actually makes it difficult to really assess how much MR is remaining. And so you may have underestimated that. Or the transmitral gradient. In terms of structural failure, there's these three types of leaflet and device problems that can happen, which is sort of the focus that I wanted to go into. One is single leaflet device attachment, which is actually the most common. It occurs about 1 to 5%. Device embolization is extremely rare. It's less than 1% of that happening, but it usually happens during the procedure and is recognized immediately by the operators. And so we often post-procedurally are unlikely to see device embolization, although it could happen. And then leaflet injury, whether that's leaflet tear or perforation. So just want to present case 2. So this is an 81-year-old male who has history of smoking, COPD on home oxygen, CAD with myxomatous mitral valve, severe MR from posterior leaflet flail. He was deemed extremely high risk for surgical intervention based on the fact that he has COPD, he's not seeing home oxygen, he's quite frail. And so he ended up having a mitral clip with an XTW to a lateral A2P2, XTR to the center of A2P2, reducing the MR to mild. So this was one day, these are images taken one day post-procedure. This is a sweep of the peristernal long axis on the left side, and then a short axis actually done from the subcostal view. But what we can see here is, first of all, the leaflets are very long, redundant. They're very mobile leaflets. And so the clip is actually moving quite a bit, as you can see here. But if looking at the sweeps, you can see their attachments. This is sort of sweeping laterally to medially. You can see that they are attached to the leaflets at this point. And the mitral regurgitation, very eccentric, somewhat difficult to see. You really don't see the vena contractor of the PISA. There's certainly shadowing from the clips themselves, but it doesn't look, severe. There seems to be reduction to at least moderate, mild, moderate. On the short axis, you can also see it's very mobile still, the leaflets and the clips themselves. It may be somewhat hard to appreciate the fact that they're attachment to the posterior leaflets, but I think it's probably better shown in that sweep of the peristernal long axis. This is a very off-axis 4-chamber view. And again, the imaging is difficult in this case, but with a color Doppler, you don't see that significant mitral regurgitation, and they ultimately classified it as mild to moderate residual mitral regurgitation. The patient actually felt better, but then 6 days later, after being repatriated back to the hospital, the sending hospital, he developed worsening dyspnea and was actually hypoxic suddenly on 5 liters of oxygen. And so when we repeated the echocardiogram, I think I felt it was difficult to appreciate all this, but you can see they're still very mobile. And perhaps the lateral clip is slightly more, I know the clips don't play as smoothly as I would like them to, but maybe there's slight more mobility to that, independent mobility to that lateral clip. And then if we look more at the more views in the apical view as well as the 4 and the 2, you can see on the 2 here that this is a medial clip and this is a lateral clip. The lateral clip is moving quite a bit. and the attachment to the other leaflet, I think, is unclear at this point. But you can certainly see more mitral regurgitation based on color Doppler than there was before. And maybe there's some differences in the technical qualities of the imaging that's difficult. And I think that speaks to also the challenges of imaging these post-procedure. But there was suggestion that the lateral clip seems to be detached from the posterior leaflet, given their excessive motion. The medial clip also seemed to be excessively mobile, although we did see that they were quite mobile immediately after the procedure as well. But there was some thought that perhaps it was only partially inserted into the posterior leaflet. When we look at color Doppler, it's difficult to tell based on how eccentric the jet is, but there is maybe more of a triangular shape, although it's, again, not particularly good quality. It's not a complete Doppler. So they actually took the patient based on this concern and the fact that the patient wasn't doing well back to the cath lab. And I'm showing some of the pre-procedural TE that just to highlight what happened in terms of the mechanism of this recurrent regurgitation. And what they found is, so these are bicommissural views at around 60, 70 degrees, where we see P3, A2, and P1. And they are doing explain on each of the clips. So on the more medial clip here, we can see that it's very well attached to both leaflets still, very mobile because of the length, the long and redundancy of the mobile leaflets. But then on the lateral clip, when they explain, you can see that part of the posterior leaflet is actually prolapsing again. And there's this gap that suggests that it's no longer attached to the leaflet itself. And interestingly, it was actually attached to the chordal apparatus, this lateral clip. And so I think this highlights some of the other ways that, SLDA is one of them, but you can also have chordal attachment as a result of leaflet detachment. So he ended up back in the cath lab, and then he had a repeat mitral clip placed actually between the two previously placed clips. It was an acceptable gradient, and the mitral regurgitation went down to mild residual. So just to go through some of the device-related leaflet adverse events that can happen. This was an attempt at a standardized definition of how we define leaflet injury in these cases. What does SLDA mean? What does chordal entrapment can happen? I thought this was a nice summary. We don't really have standard definitions for any of these based on my reading, but this was one of the papers that kind of tried to formalize this a little bit. So in terms of leaflet injury, it can be a tear of the leaflet as a result of the clip. That where you have disruption of the integrity, but it doesn't reach the leaflet edge. Perforation it reaches the leaflet edge. Perforation is where it doesn't reach the leaflet edge. And you can also have leaflet injury in another way where you actually distort the shape of the leaflet so that it doesn't coapt properly without actually causing any perforation or tear. SLDA they define as, you can definitively call SLDA if you have one of these three criteria. So one, you have actually confirmation by surgery or autopsy. Well, that doesn't actually help us. Two, if you by echo see for sure complete separation of the device and the single leaflet tissue, which we saw in the very first case. Thirdly, if you see failure to actually demonstrate that diastolic bridge. For the third criteria, you need all three. So failure to demonstrate a diastolic tissue bridge. You have color Doppler that shows significant mitral regurgitation through the device leaflet interface, or you have new excessive mobility of that device post-deployment. Those would be considered that you likely have or most likely has SLDA. What also can happen is chordal entrapment, as sort of seen in that last case, although that was more of sort of detachment and then entrapment into the chordae. But you can have the clips actually just partially gripping one of the chordae, like in the previous case, or both clips are actually tangled and gripping the chordae. And you can cause chordae rupture in these cases, which can lead to worsening MR. So in terms of leaflet injury, this is just still images from this review paper that I found. These are actually, again, TE images, just because we can visualize these a little bit better here. You can see the clip as marked by the asterisk. In one view, this was an attempt during the grasping, you can see that it actually is grasping the posterior leaflet quite well. It's inserted into the clip, but then later you see that it's actually created a gap. The posterior leaflet is not in the clip anymore, and this was demonstration of a leaflet perforation that happened. So coming back to SLDA, the incidence, as I mentioned, is generally low. It tends to happen immediately, most of the time, either at the time of implant or prior to discharge. So on your immediate post-procedure TTE or 1 day post-TTE. But they can happen later during follow-up, usually up to the 30 days, but it has been, in 6 months to 1 year, that can also happen as well, but they're considered more late. It's more rare later on because you have that fibrous encapsulation of the tissue bridge, so they tend to stabilize the leaflet more, and so SLDA is less likely in those times. Majority of the time, they actually involve detachment from the posterior leaflet. I think there's probably multiple reasons for that. And then usually there are the consequences of either there was insufficient grasping, so you don't have enough grasp of the leaflet, and so part of that leaflet tip just fell out of the clip. Or if you did have adequate grasping initially, there was some tear or perforation that actually caused the leaflet to completely detach from the clip as well. So leaflet tear or perforation can actually cause you to have complete detachment in SLDA. The mechanism is really increase of tension on these leaflets. So they tend to happen when there's larger coaptation gap, there's very severe tethering, so that you don't have as much ability to grasp onto those leaflets. You're going to more likely get perforation leaflet injury when you have short or very calcified leaflets. If you have multiple attempts at grasping them, and remember these clips have these like hooks and frictional elements to them, which is more likely to cause injury on the leaflets. And annular sclerosis or calcification of the annulus can also increase the likelihood of these adverse events because the annular calcification actually reduces the flexibility of that annulus to leaflet base dynamic, and so that can create more tension on those leaflets. They obviously will occur more often in complex valve lesions that have larger gaps, more calcification, for example. The other setting in which they're more likely to occur is actually long-standing secondary MR, just because you've dilated the annulus quite a bit, and you've pulled the leaflets apart more, and so you're going to likely to induce more tension on them once you put the clip. It was a very interesting study that I was reading about, which is a in vitro animal model where they looked at what the relative stress of the leaflets on the mitral leaflets at different heart rates and in different types of configurations, whether you had complete grasping versus marginal, so not quite complete grasping, but symmetric grasping, marginal but asymmetric grasping, either marginally grasping the posterior leaflet versus marginally grasping the anterior leaflet in the setting of posterior leaflet prolapse. But basically, at higher heart rates, you actually increase the amount of stress that you have on the leaflets, as can be seen by this green color in these color plots. But also, when you have any sort of marginal grasping of one leaflet, either asymmetric or symmetric, interestingly, it favors more tension on the prolapsing leaflet, which is in this case the posterior leaflet. So for various, I think, mechanical reasons, it tends to actually increase the amount of stress on that posterior or prolapsing leaflet. And so that might be one of the reasons that we see a lot more SLDA of the posterior leaflet, or just detachment from the posterior leaflet and attachment to the anterior leaflet. There was initial concern about if we increase the amount of the longer arms with the exterior and anterior devices, that we're going to introduce more force applied over that area. And so that might actually increase the amount of these leaflet adverse events. If they also had increasing amount of grippers, these hooks, the active locking mechanism, and the device stiffness may actually introduce more of these leaflet adverse events. But that ultimately was not the case. The fourth generation devices actually were introduced more so to reduce the SLDA and the likelihood of improving leaflet insertion with these wider clips and having these independent grasping mechanism. And in this most recent, fourth generation, the SLDA rate is somewhere like 1.6% in a registry data. Or in this cohort study. So much less likely actually with the newer generation for various reasons. But ultimately, I think what I've described really emphasizes the importance of pre-procedural planning with imaging of transesophageal, transthoracic to really define the anatomy and pathology. You need very clear, proper clip selection for particular patients. Certain types of clips with particular types of arms lengths are going to be more favorable for certain types of valves. And then the importance of intraprocedural guidance to really get a good grasp to avoid these types of leaflet events, I think is highlighted based on what I mentioned. So SLDA can often be confused with other things. So SLDA is defined by this complete detachment of the leaflet from the clip, but you can have partial leaflet insertion as well. You can have misalignment between the clip arms and the leaflets that make it look like they're not quite completely attached. And then any residual jet because of just residual MR may be confused for the presence of SLDA as well. So just something to be aware of. So I'm wary of the time here, but I thought I'd go through the last case to highlight the presence of recurrent MR a couple of years later. So this is a 73-year-old male with prior bioprosthetic ABR, atrial fibrillation, hypertension, CKD, prostate cancer, comes in with heart failure exacerbation and acute MR because of P2 prolapse and flail. He undergoes 2 clips to A2P2. But at the end of the first clip, they actually see a new mobile echo density, which was likely a torn cord, but it was still mild residual MR at the very end. And so the day 1 post-procedure echo showed, no evidence of leaflet tear, no SLDA, but there was still some posterior prolapse and with moderate mitral regurgitation. So because he was asymptomatic, he was followed serially over the years. 4 years later, though, he now develops NYHA class 2 symptoms. And so he gets a repeat echo. Now we can see that there is, these are the parasternal long axis images. You can see on this zoomed up view here, there's towards the very end of the clip where they're sweeping more medially, you start to see this mobile segment. As I mentioned, there was the question of a torn cord, but there also looks to be a flail segment of the posterior leaflet as well. I'm not sure if that's towards the very end of the clip. That perhaps the posterior leaflet has residual prolapse and flail. There's quite a lot of MR. I mean, it's difficult to see on this color imaging here, but you can see there's quite a bit of red flow with aliasing. And then when we look, there's good tissue bridge formation. You don't see any evidence of SLDA here. And then you can see it still attached to both leaflets, but with more sweeps. This is in the apical forechamber. Again, it's not clearly demonstrated, but maybe there's a suggestion of residual posterior prolapse, and there's quite a bit more mitral regurgitation now. And you can sort of see a PISA that's behind the clip, or that's at the clip there. So this patient ended up going back to get a transesophageal echo. And again, I'm showing some X-plane imaging across the commissural views. And what we see here is actually in this medial A2P2 segment, you see this posterior prolapse with flail. And this is actually the source of predominantly where that regurgitant mitral jet was. If we X-plane through the clips themselves, they're well attached. There's really minimal regurgitation lateral to that clip. So that was actually the pathology of why this patient had persistent, had new symptoms now, and now severe mitral regurgitation again. So he actually underwent a repeat clip and got it down to mild moderate mitral regurgitation. Recurrent mitral regurgitation after TEER is more common in TEER than in conventional mitral valve surgery. In the Everest 2 trial, this was about 12.3% of patients actually needed repeat or a mitral valve surgery during the 12-month follow-up. In retrospective cohorts, the incidence at 3 months was about 3.7% and 9 to 10% at 12-month follow-up. Patients with recurrent MR actually have worse prognosis. So this is why it's relevant to actually reassess the mitral regurgitation in these cases. They're more likely to experience heart failure hospitalizations, more likely to have symptoms, obviously more likely to undergo repeat mitral valve interventions. And they actually have lower survival based on this study at 3 years. what we can see here is in patients with recurrent MR, they actually have a reduction in RVSP, but then end up having a recurrence with increased RVSP again, so their pulmonary pressure increase. There are several mechanisms of recurrent MR. You can have SLDA. As I mentioned, you can have SLDA later, not just in the acute phase. You can also have loss of leaflet insertion, either because you end up having some tear or perforation later down, not necessarily acutely. So you can see here what part of the tip of the posterior leaflet has actually come out of the clip here without complete detachment as an SLDA. You can have leaflet tear or new worsening prolapse, or you have functional etiology. And these are also all suggestive of the progression of the initial disease process. If it's secondary, you have progressive dilatation of the LV and LA, or if it's primary, you have worsening degenerative disease to the mitral valve. In follow-up of these patients, they're actually more likely to have loss of leaflet insertion than SLDA, and progression of their initial etiology. So whether it's worsening prolapse or worsening functional etiology. This study basically showed very similarly when they differentiate between primary MR and secondary MR. Interestingly, secondary MR, you could, in one patient actually, they developed SLDA because it dilated so much that the leaflet just came out of the clip. So in terms of mechanisms of recurrent MR, what is known is that in primary MR, they're more likely to develop SLDA, loss of leaflet insertion, leaflet tearing or worsening prolapse. Whereas secondary MR, it really comes back to the initial pathology of the MR. Progressive LA and LV remodeling is actually the most common reason for them to have recurrent MR, in which case they may develop tears or SLDA as a result of that. In terms of the predictors of recurrent MR, in primary MR, having a flail leaflet actually makes it more likely for you to have poor grasping. And in secondary MR, having an increased LA volume increases the tension on the leaflets and more likely to develop recurrent MR. In both cases, if you have residual MR at the very end of the procedure, you're actually going to be more likely to have recurrent MR because residual MR increases volume overload and can contribute to adverse remodeling that then results in further tension and mechanisms of recurrent MR. So that's why it's so important initially to try to reduce the MR as much as possible. I don't have time to go through tricuspid tear sort of from an assessment, but really it's very similar theme of the fact that PISA quantification by EuroA is difficult in these cases. We use what we can apply from assessment of native tricuspid regurgitation to post-tear patients. But I think the one thing to note is that the likelihood of SLDA post-tricuspid tear is much higher. It's about 7%. And there's a couple of possible reasons. We don't see the leaflets as well when they try to grasp during intraprocedural imaging because they're shadowed by either prosthesis of the aortic valve, by mitral annular or aortic calcium, by hypertrophy of the interatrial septum. And sometimes they just have very poor views of the tricuspid, and so you don't get that good initial grasp during the procedure. There are some anatomic differences as well. The tricuspid leaflets are thinner, and so maybe more prone to tearing. And kind of going back to the initial case, sometimes we're grasping at the commissural sides, in which the leaflets are actually smaller in that area, and so maybe more prone to an inadequate grasp at that point. And then we see tricuspid annular, much more significant tricuspid annular dilatations, which can actually create more tension on those leaflets. So there are a couple of treatment options if you do develop regurgitation, but at the end of the day, this really requires a heart team discussion. These patients are obviously too high risk for surgery, so surgery is often not an option. There has been cases of repeating that clip, as you've seen, with good success. Other more interesting but very very off the cuff kind of treatment options, but has been done at St. Mike's, is actually lacerating the clip in the setting of recurrent MR with post-tear. So lacerating the anterior leaflet so that you kind of dislodge the clip, you create an SLDA, and then you implant transapically another mitral valve, like a Tendyne valve, or you can actually implant occluders for residual MR or plugs. But those are really, case reportable types of situations. So I'm just going to end it there. Thank you very much for